Hello and welcome to my channel. My name is Peter Abraham. I'm a second career registered nurse with a focus in hospice and palliative care. I'm also a certified end-of-life doula through the International Doula Life Movement. If you're new to this channel, welcome. Thank you so much for taking the time to visit. In this channel, we talk about things related to death and dying. After all, we're all going to die. It should not be a mystery or a stigma or a conversation that we keep putting off. We plan for birth. We have baby showers. What are you going to name the baby? Is it a boy or a girl? Clothing's picked out before the baby is even born. Let's get a room ready and all these different plans. Why can't we do the same before we die? To me, life is about living. But in order to live, we shouldn't have to fear the end result. So we'll have video discussions for my fellow hospice and palliative care nurses. Monday, we had a discussion on the FAST scale. We'll have discussions for my fellow end-of-life doula. Wednesday was giving a progress update, both on upcoming continuing education classes that I will be teaching as a part-time instructor at the International Doula Life Movement school, as well as a book that's currently in progress mainly for end-of-life doulas, but in all reality, my fellow hospice nurses and holistic nurses might benefit. It's looking at care planning for physical, emotional, social, and spiritual needs as one approaches end of life, and not just end of life, chronic illness, terminal illness, the whole gamut of issues that we face as we're getting older. And this happens when you're very young. Today's discussion is going to be for my caregivers and for my family members. So the topic of today's video is, what does this 6-month prognosis mean? What is a prognosis? Why 6 months? My neighbor, their loved one was on hospice for 4 years. This must be your state that's 6 months. There's a different type of hospice now. Hospice is about support. This death thing doesn't really matter. It must be your state or your city that this conversation's about. So I want to talk about that today, and I do apologize in advance for my camera. It's having some focusing issues. I am filming in the evening, and it does better with natural lighting, and if I don't move a lot. So please bear with me for that. Now, before we go into the topic of today's video, talking about prognosis, 6 months, how does the calendar in hospice work differently than a traditional calendar that most people are used to? So before going to that discussion, I want to talk about the pillars of building resilience. So I am often asked, and I've heard on Monday with the International Life Movement Summer Summit 2025, we had Dr. Cynthia Pan on, and she mentioned this too. How can you do this day in and day out? How can you choose to work with dead people, people that are dying? How can you do that? And it's about building resilience. And it's not just about death. I believe that if you build resilience as you live your life, you will handle the storms that come at you much better than if you don't have resilience at all. So for me, there are 3 pillars that make resilience. I don't speak too often about pillar 1 just because I do have viewers and listeners that even though I say faith and religion are different, they're not there yet. So pillar 1 is my faith in Christ Jesus. Pillar 2, that's been a real struggle for me this year, is forgiving. Forgiveness. They don't have to earn it. Just give it. It helps me more than them. It's a struggle. And pillar 3 that I encourage all my viewers and listeners to get engaged in is, what are you grateful for? So what are you grateful for? So I'm grateful that I've finished up to chapter 10 draft of my new end-of-life care plan book. I'm grateful that it looks like that we're going to break 500 books sold this month. It's been a slower month compared to other months. I am an author, and not Stephen King or Dean Koontz or other, Barbara Carnes or other famous people out there. I am one of the few in the hospice and palliative care space, and recently in the doula space. One of my books that is doing rather well in the doula space is a crucial end-of-life conversation book for any end-of-life professionals, but particularly doulas. Chapter 1, Death and Dying Conversations. Chapter 2, Nutrition. Chapter 3, Hydration. Skipping ahead, Chapter 10, Palliative Care Discussions. Chapter 11, Hospice, and so on. So the sales of that book is going well. So I'm grateful for that. I'm grateful for you coming here and spending some time watching and listening. What are you grateful for? Always feel free to comment in the comments below. And if you like this type of material, not only like, but hit the subscribe button, including the bell notification. I've been trying to publish videos every Monday, Wednesday, and Friday, but at least Wednesdays and Fridays. It depends on how the week goes. So let's dive into today's topic, which is going to be what is often referred to as the talking head topic versus let me take you through an article or a book. So when we talk about 6 months, 3 months, I still remember my one very rare type of ovarian cancer, a young 30-year-old patient. This is a time I wish the oncologist zipped it completely, but instead the oncologist told her 2 weeks. And I would rather the doctor say 6 months or less and let us nurses, as we're seeing the patient, as we're exploring and interviewing, and I've done videos, by the way, of how admission nurses should interview and how case managers should interview. We could build a better prognosis than doctors. I don't mean that to sound arrogant or sound puffed up, but in reality, we see our patients far more than any doctor typically does. And if we're doing our job correctly, we can be rather accurate. We'll never be God. I cannot claim to be God. But we can be rather accurate on our prognosis. And but let's get to let's stick to the topic, and I'm going to try not to get to too many rabbit trails in the discussion. Why is this different than the traditional calendar? Most people are, hey, if I say I'm going to meet up with you, let's do this. I'm going to be presenting at a coffee and talk, so to speak. I think that's the actual name of the group, Coffee and Talk. It's a group of healthcare professionals that I've been invited to be a part of on Friday, August 29th. Location yet to be determined. It starts at 10. And for right now, I'm planning on a 15-minute presentation of what is a death doula? Why would anyone need a death doula? How do we collaborate with the different healthcare teams versus competing with them? How I might be able to help the different people there and how they can help me, and try to do that in 15 minutes or less. Please cheer me on, because most of you know I tend to be verbose. So if I put that on the calendar, every single day is a day closer to Friday, August 29th. And if you're watching this video after Friday, August 29th, and it's going to be published on Friday, August 1st, so you would have caught it 28 days later, it's already happened. We're in the past. So that's your traditional calendar. You write a date and the time, or you might just put it on per date. And as it gets closer, we're getting closer. And then we're there, and then it's gone, and we can't go back in time. You might have heard of the fiscal calendar that some corporations use. May 31st to June 1st, if I'm doing the nomenclature correctly. But the fiscal calendar is still like a regular calendar from the perspective if somebody says, I'm going to have my annual report done on such and such a date on their fiscal calendar, every day forward is a day closer to that event. When you get to the day of the event, it's the day. And when you pass it, it's in the past and you can't go back in time. Hospice's prognosis calendar is not like either of those. And this is what causes the greatest confusion to everyone who's not in the field, so to speak, because it's a moving target. And the best way to give you an example of that moving target is to give you two contrasting examples. So example number one is I'm going to talk about, not that I was not his hospice nurse, nor did I work for the hospice agency, in full transparency. But let's take the case of President Jimmy Carter. He was on hospice about 2 years, maybe a little bit more, maybe a little bit less. When President Jimmy Carter was admitted, the hospice register nurse, it has to be a registered nurse or nurse practitioner, is the typical one, it's typical registered nurse, goes and does an evaluation and has a conversation with the hospice medical director, not Jimmy Carter's physician, the hospice medical director, and they have a conversation. And it may go like, and just so you know, this part I am making up because I don't have access to President Jimmy Carter's record. So it might be, okay, doctor, Jimmy Carter has XYZ type of cancer. He's no longer receiving treatment. And just so you know, hospice could be for a wide variety of diagnoses. A prognosis is a time to live, not a diagnosis. You do not need a terminal diagnosis to be on hospice. You need a terminal prognosis. So I'm having this conversation with the doctor, the medical director. This is why I believe President Jimmy Carter is number one in a terminal state. He could die at any moment, and he may make it 6 months or less. And I'll go over the facts and my observations. And while I will get vital signs in our field, vital signs mean close to zero. I typically will encourage all my families and my caregivers, unless I or your hospice nurse tells you to take vital signs, or maybe you have a medication that you're given that has to be given only within certain parameters, please don't take the vital signs. It doesn't tell you how much longer. I rarely will ever use it in a prognosis, and I do mean rare. I would have to think for a while, have I ever? I'm just putting it out there for the possibility's sake that one day I might. So I go and I make that call to the doctor, and the doctor reviews this with me, and we review the medications, and my camera's acting up again. Not that I'm anything to look at. But doctor, if the doctor's in agreement, by the way, as a hospice registered nurse, I have the right to say, no, I'm not admitting. Doesn't matter that the doctor said, I mean the person's doctor, doesn't matter what their position is. I think this person has longer than 6 months. I have the right to say that. I have to be able to back it up. I have to be able to document it, why. And yes, they may send out another hospice nurse for some companies to, quote, get it done. But then if they assign it to me as the patient to me as a case manager, I have this right to say, not on my nursing license. Because unless something drastically changed, I'm not going to commit Medicare fraud. I'm just putting that out there because there is an ethics to this. It's not cut and dry. So for President Jimmy Carter's case, again, I don't know the medical record. Obviously, he was admitted. And every benefit period, 90 days, this is behind the scene, 90 days, that gives you your 6 months. And then an unlimited number of 6 months with every portion of it, the fine print that if that patient ever goes outside of the terminal state, they no longer have a terminal prognosis, the hospice agency has a duty to discharge that patient for failure to decline. They have a duty to not commit Medicare fraud. And again, my camera's acting up. So I feel like brick in the middle. So with this, Jimmy Carter, every benefit period, the hospice agency in question had to submit its electronic recertification paperwork, electronic, to CMS, the Center for Medicaid Services, why Jimmy Carter still should be receiving hospice services. So in this case, the hospice calendar kept being pushed out, pushed out, pushed out. It wasn't, as time gets closer, President Carter has to die. No, no, at all. It's that as each time he gets certified, it's pushed out another 6 months. Or I should say, to be more accurate, it's pushed out another benefit period. So it's pushed out another 90 days or 60 days, whatever the case may be. So we're not getting closer as in a real calendar or a fiscal calendar. So that's Jimmy Carter. That's one case, 2 years. And as a hospice registered nurse, I had a lung cancer patient on for 2 years. I had a COPD patient on for 2 years. I've had other, the neurological conditions are more prone than not to being on longer. They're harder to keep on. But I've also had patients where I'm admitting them, they're dying the next day. So let's talk about a contrasting case. I remember my pancreatic cancer patient. I did not do the admission. I'm going to see the patient for the first time. It was a Filipino family, so I'm dealing with cultural issues. I'm thankful that they speak English. I'm not good. This is I'm good with medicines. I'm not great with anything other than English, my flaw. But I see the patient for the very first time. And most of us who are in hospice who have been doing this for any length of time, we could walk into a room and just using all of our senses can tell when somebody's on the short end. And so after seeing this gentleman, I go and I sit down with the wife. I was working for Grain Hospice in York. They had a standard where when somebody's admitted to hospice, and by the way, I appreciate their standard, nurses visit a minimum of twice a week to start. Families can ask them to back off, so to speak. And then the nurses have the right to say, we're going to do it more often. And if somebody is in the last 2 weeks of life, we would come daily, 7 days a week. May not be me. I don't necessarily work all 7 days. I have worked for other agencies that actually have to be actively dying to get that 7-day-a-week visits. But for Grain, they had very high standards, so I appreciate that. And so I sat down with the wife and I said, you know, when he was admitted, they told you twice a week. But I think he has a month or less. This was my first time seeing him. I wasn't sure if it was going to be a month, but I wanted to go a little bit more liberal in case I was wrong. I didn't want to scare her to pieces from a point of view. So I said, I'm gonna be back in a day or two. We're gonna up them to 3 times a week. And when I get back, I'm gonna reassess because things are moving fast. So I told her 1 month or less. I come back about 2 days later and he's going fast. And so depending on the situation, and to be honest, I don't remember if I had the conversation with the gentleman or not on this regard. I do remember with talking to the wife because this is very emotional. And I told her we're now going to daily visits. Remember, 2 days passed. So it went from a month, I go 2 days later. So instead of being, let's say, 28 days, or depending on how many days are in the month, maybe it's a 28-day month. Now we're 26 days. I go 2 days later and I'm telling her I'm putting him on daily visits. We're at 2 weeks or less. He's starting to transition. He's starting to transition, this in and out of consciousness, this lethargy. He's starting to transition. And he did not make 2 weeks. The hospice calendar is moving. It's not black and white. It's not cut and dry. I still remember my Parkinson's, end-stage Parkinson's patient who used a walker, and as I'm like standing by the kitchen table, it was a very tight room. I couldn't really go and help her. And she's coming to the kitchen table and she has a planner in her hand and she puts it on the table and she goes, "I want you to write down the date and time." And I thought, my next visit, I could put the date down because we try to come around the same, Monday, Wednesday, Tuesday, Friday. But I can't tell you the time because we charted out that day and sometimes we have to adjust. No, no, no. Write down the date and time of my death. She was serious. No pun intended. She was deadly serious. When I told her, I can't do that. With the politeness, a straight face, she said, "Peter, maybe I need a more experienced hospice nurse." Um, and I am experienced. I was not offended. I said, "I'm sorry, none of us are God." And to be very frank with you, there have been times I've been accurate within the hour. I still remember one Hanover, Pennsylvania family where the daughter called and said, "Peter got it down to the minute." And for full transparency, I never gave minutes, ever, ever, ever. I don't even give hours. I said we were looking at minutes to hours. I used the word minutes to hours, which could be 5 minutes or 3 hours or 4 or 12 or 23. I don't give exact dates and times. I still remember working for a Care hospice. We're going to come to an end shortly. I still remember working for a Care hospice of York, PA, both one for Golden Living and under Medicis. And we had a hospice nurse. She was good from a clinical point of view, but she had a habit that she would tell families that they're going to die by Wednesday. And by the way, if you're a hospice nurse that does this, please stop. You do you, but please stop. Don't do that. Oh my word. I still remember the patient. I had York County. She had all of Adams County and maybe one county past Adams County. Um, and she told this patient Wednesday. And I was scheduled to work that weekend. And I'm like, if he's still alive come Saturday, Wednesday came and went. I told her first name was Jennifer. Jennifer, what did you tell the family? Oh, I told them I was off this time. It's going to be Thursday. Thursday came and went. Friday came and went. Saturday, I'm driving out there, and this was far out of my territory. It was like a 1.5 to 2 hour one-way drive. I think it was Fayetteville. This is way past Gettysburg. And I still remember getting to the home, walking in, getting directed to the patient. I could tell when I got there, he was actively dying. I knew the moment I walked in the room, it could have been within minutes to hours to a day or two. Just so you know, when somebody's actively dying, I had a patient I put on daily visits. They were actively dying from December 23rd, 2018 to January 9th, the day I pronounced them, January 9th, 2019. So somebody could actively die for several days to a week or two. So I literally just got in the room. I could tell anytime. And one of the adult children came in, one of the sons, and asked me, "Jennifer said Wednesday, then Thursday, then Friday. What's your clinical judgment?" I said, I'm sorry for, this is not there's part art, part science. What I can tell you is we're down to the finish line. We're looking to minutes to hours, but it could be tomorrow. It could be the next day after that. This is, right now we're at the point where it could be any time. And I had my clipboard with me with my brain sheet out, and nothing was written on other than his first name, date of birth, and age and primary diagnosis. Uh, he looks down at the clipboard, sees that I didn't even get vital signs or anything else. He said, once you complete your assessment, come back to me and give me a more accurate answer. Uh, the vital signs don't say when. Vital signs mean close to zero. What matters towards the end, in the minutes to hours, the biggest clues, breathing changes. Rapid fluctuations between hypoventilation, breathing very slowly, and hyperventilation, breathing very fast. The more rapid those become, or the frequent changes, maybe slower, 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 uh, or faster, 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 the more rapid the changes, the closer somebody is to taking their last breath. And while there are signs such as the death rattle, death rattle for non-congestive heart failures is a very late sign, typically within minutes to hours after that. Congestive heart failure, you could have the death rattle for a couple days. But I had to go back to the sun and say, we're still looking at minutes to hours. And I stayed and I talked and I ended up driving. I didn't drive home. I had several other, that was such a long day. I think I got home that day around 7, 8 o'clock. And I still remember, I think it was around 9 or 10, I get a call from the family that the patient died, and then I'm driving back out to pronounce. So for my family members, my caregivers watching this, I do appreciate you and your time. But when we talk about a terminal prognosis, number one, we're not talking about a diagnosis. You may get told they have a terminal diagnosis. It's not that you were told wrong, but that doesn't get you in the hospice. Hospice requires, it's a federal requirement in the United States of America, it requires a terminal prognosis. As a good hospice nurse, you don't have to, if you maybe there's no terminal diagnosis involved, a good hospice nurse can present the case to the doctor, and this is why I wrote the book, Mastering Hospice Eligibility, why the patient should be on. I've had patients on for hip fracture. I've had patients on for femur fractures, sepsis, and other cases where there's no local coverage determinant. We do not have to use the word terminal diagnosis. Now, Medicare will we have to pick one to be the primary diagnosis, but it does not have to be the traditional terminal diagnosis. So it's about prognosis with hospice. It's a moving calendar versus a traditional calendar or a fiscal calendar. And if you're a family member or a caregiver, and if I am not being clear in how I'm sharing this with you, you will not offend me if you ask in the comments below. If you have criticism, and I am so sorry for what's happening with the videos. I'm normally filming this anywhere between 8 and 4 during the day where I'm using natural sunlight, and one of these days I'll buy some additional lighting for the room, LED above. I'm finding out with the Panasonic Lumix G97. It has more what they call breathing, where it's just refocusing back and forth. But that's where we're at for today's video. I so much appreciate you and your time, and subscribe, like, and thank you again. Take care.